My name is Eli Manna. I'm a registered respiratory therapist. With me today, I have Dr. Riccio, Dr. Foley. They're both seasoned anesthesiologists, and they're going to be sharing their thoughts with us today regarding the use of high-flow nasal cannula and SuperNO2VA nasal positive airway pressure in the OR, outside the OR, and post-operatively in the PACU. Dr. Riccio, Dr. Foley, thank you for being with us today.
Thank you.
Hi.
Dr. Riccio, you use mostly the high-flow nasal cannula in your practice, and Dr. Foley, you use probably more of a SuperNO2VA in your practice as well. And I'm glad that you're here so we can you can both kind of enlighten us on how to use it, when to use it, and some of the benefits that patients can get from these two modalities. I'd like to start first of all with just the ease of implementation of these therapies on the patients. And we'll start with Dr. Riccio. How simple is it to apply the high-flow nasal cannula in the OR?
So I think the biggest hang up to having the high flow is just having the system set up in place. But once that system right here is set up, the nasal cannula itself is no different than a standard nasal cannula that we use every day. So I would say my providers are very comfortable using this device, and it requires very little education.
Okay. Dr. Foley?
So on the opposite side of that is the SuperNO2VA. Basically, all you need is oxygen tank or O2 from the wall or even from the anesthesia machine. Very simple in that respect. Putting the mask on does take a little bit longer because you have to make sure that you have a complete seal around it so that you can measure your end-tidal CO2 and that it's going to deliver the pressure that it's required to deliver.
Okay. Yeah, it does take a little bit of practice, but once you put it on a few times, we probably get the hang of it. Dr. Riccio, what are some of the benefits of using high-flow nasal cannula in the OR?
Well, I would say the primary benefit of high flow is its ability to oxygenate patients, whether those patients are undergoing airway surgery or they have a difficult airway and we're attempting to secure their airway. During our attempts at intubation, I would say the high flow is the best at maintaining oxygenation.
Okay. And Dr. Foley, in contrast, how beneficial is SuperNO2VA to your patients?
Very beneficial. So basically, it's great for pre-oxygenation, apneic oxygenation, as well as post-operatively when you extubate the patient to the SuperNO2VA. Yeah. So it's good for transport. It can require, and actually even intraoperatively at times, where switching over from a single lumen to a double lumen, we'll keep that on, and then I can still ventilate that patient in between, not just with apneic oxygenation, because you can ventilate with the SuperNO2VA.
Yes.
So that actually helps as well.
Okay. And do you feel that the same benefits apply in the OR and post-op in a PACU from a high-flow nasal cannula standpoint?
I do. I think it would be helpful if we sort of broke it down into specific instances and we can sort of discuss why we think one is better in some areas than others. Because whereas both can oxygenate patients, when you are switching out airways or, attempting to intubate, I would argue that the high flow is better because it is less obstructive and it doesn't get in your way, as opposed to this, which tends to be a little bit bulkier. But while they both oxygenate, I think.
Sure. So that was a great segue. Yeah, that was a great segue. So thank you for starting with that, Dr. Riccio. So Dr. Foley, let's talk about difficult airway management while using the SuperNO2VA. What are your thoughts on utilizing it to establish an airway?
So two things. Christine made a good point. Both of them can pre-oxygenate. And I think what's key about the pre-oxygenation on both of them is that, you have those patients with the either high flow or with the SuperNO2VA, that you're going to take big, deep breaths in through the nose, and the mouth has to be closed on both. So that's the system. Because with high flow and, even with the nasal CPAP, if your mouth's open, you're not going to get that pressure or that you need to oxygenate. As for then, basically, if for difficult airway, basically what the airway experts are saying is that really you should be going directly to video laryngoscope. So when it becomes the concern that it's bulky, it is not bulky, even with direct laryngoscopy or with a video laryngoscope. But if I'm going to have a difficult airway, I go straight to video laryngoscope, which then the SuperNO2VA does not get away in. I mean, she also made the good point of that, you know, for intraoperatively, if you're going to be doing rigid bronchoscopy or laser surgery, the SuperNO2VA is not an indication for that. That is bulky. It gets in the surgeon's way, where high flow is very nice and it works very well for that.
So with respect to that, right, like we both agree on this concept of like peri-oxygenating a patient during attempts at difficult airway management for these patients, right? So both can pre-oxygenate effectively. You know, both will post-oxygenate, let's say, but we're going to have an ET tube for that, right? So it's this idea of apneic oxygenation while attempting to secure an airway. The SuperNO2VA is great, like if you are intubating orally, but a lot of times, like I will intubate nasally in a difficult airway scenario, and they can't wear this when I'm doing this fiber optically, right? So for me, the high flow, you can intubate fiber optically nasally while wearing a high flow, whether awake or asleep. So that's a utility for the high flow in that scenario, especially if the patients are awake and I'm awake intubating them. High flow I also think is better because 1, it's more comfortable for the patient. 2, it decreases their work of breathing. Like 3, you know, we're not strapping this tight thing on, and I have the option of going orally or nasally. So I would say high flow in management of difficult airway is a little bit better.
So for me, I will still use this for an awake intubation. Patients seem to tolerate it very, very well, especially, so let's say, I mean, depending on where you are, you know, you have a lot of community hospitals that might not have high flow, and then in the OR, you know, you don't have high flow, but you need to, the patient needs positive pressure ventilation. So SuperNO2VA works very, very well. Now, as for nasal intubation, you are correct. That is one of the things. For me, I tend not, unless there's a strong indication to nasally intubate someone, I do not, because if you get into bleeding and now you have a difficult airway, that's my philosophy, but that's just me. So I think both do the same thing. For me as well, as like when I would have to go to the ICU, I actually would bring this and do an awake intubation, putting this on, which would keep the patient oxygenated as well.
Okay.
If especially or areas that you might not have the high flow. That's what's nice about this. It's portable. You just need to take this little packet with you, and you're good. But you're right. The nasal intubation, definitely you cannot do that through here.
Correct. Great viewpoints on two different therapies. Let's just move on to the microlaryngoscopy surgery and see how we can maybe apply.
We can't.
We can't.
We can't apply it to the SuperNO2VA doesn't.
Yeah,
will not.
we win.
Correct.
High flow wins.
Correct. So that was easy and simple. All right. So let's move on to the NORA environment then. And how we can use high flow versus SuperNO2VA, and how it can make you know, our workflow better and improve our patient outcomes. So Dr. Foley, I'll start with you this time, and if you don't mind, just gonna share your experiences using the SuperNO2VA in those environments.
So using the SuperNO2VA in the NORA environment, like the GI suite or any other place, radiology, or you know, interventional radiology or any other places like that. So the thing is, you know, the best way to use the SuperNO2VA is you need to put that on when the patient's awake.
Yes.
The patients actually tolerate very, very well. The nice thing also about the SuperNO2VA is you can monitor end-tidal CO2, which is very, very important, especially when you're doing deep sedation on these patients. So I will put that SuperNO2VA on the patient, put it on tight enough. I tell the patient that it's tight. They know it, they tolerate it, it's not a problem. And the reason why I do that is I have it hooked to my end-tidal CO2, so I know I have a good CO.
Yes.
So once that's done, that's when I will start my deep sedation. Now, you know, depending on where you are, for example, one of the things like IR, right? You are over here, the patient's here, you're near, you know, you don't want to be next to the patient because you're going to get all this radiation, so you have lead on and you're further back. That you can use an extra long anesthesia circuit, and if there's any problems, you can actually ventilate the patient from afar if you have a good CO. Unlike the high flow, you do need to change over into a mask. So there's a little bit of a rescue in that respect. So that helps. So those are the things. The other thing you don't need the anesthesia machine as well. So that's the other thing. So you have the ambu. Right. Just like the high flow, you just have your high flow machine. But so that's where I think it's very, very important. So I will bring it and use it in all the neuro places because I find that it really helps me with that.
So it's basically both a nasal positive airway pressure mask plus a resuscitation mask.
Correct.
All in one. Thank you.
Well, how do you ensure that they're going to breathe nasally?
So, I mean, so you...
Especially in IR.
IR, well, they're actually here.
Right?
So you can, I mean, you never can tell. And the same thing with high. So, I mean, if you're... The one is making sure that they are breathing and sealed before you kind of go off to sleep. But even with the high flow, you're not going to get that same thing because if the mouth's open, you're not giving that same pressure, right, as you would as a closed system with the high flow. So, there's never a guarantee that they're all going to breathe nasally. And if there's a problem, then I would have to go adjust and readjust the patient's head so that I'm closing off the mouth because that's what you really want in this case.
Do you ever, before you put the mask on, put a nasal trumpet in just to maintain that that you have a patent nasopharyngeal airway?
No. Because
I do sometimes.
Yeah, so no, because I figure if I have a good seal and I get my end-tidal CO2, that's telling me that I'm exchanging the air. I guess that's probably the reason why.
And then you're able to visualize the patient breathing from the bag.
Yeah, so if it's far away, let's say, when, I talked about, for transport where you don't have end-tidal CO2 available somewhere, at least if you're using the ambu or even the anesthesia machine will have your end-tidal CO2, but you can watch the patient, the ambu bag ventilate and move so you know that the patient's exchanging air, which is really nice.
Yes.
Yeah, that's a big downside of high flow is that you don't have end-tidal CO2 monitoring. I mean, I will say, if you are concerned about it in GI, if you are not doing an oral procedure like an EGD, you could put a simple face mask over the whole device and put your end-tidal CO2 monitor in there, but that's an extra step and an extra mask and that sort of thing.
Awesome. Well, thank you for that information. Let's talk a little bit about using both modalities in a PACU. So a patient is done post-op, they're in a PACU. So how do you feel, or can you share with us your experiences in using the high flow in the PACU post-operatively, please?
So if I have a patient who is struggling, whether it's from residual narcotic or residual anesthesia, or they're hypoventilating for physiological reasons, and we're on the fence where we may have to reintubate them. Sometimes putting them on a high flow device can prevent that because it can make their work of breathing a lot easier. It can reach their, inspiratory demands can be met, and it buys them a little bit more time for the rest of our anesthetic to wear off, and we can oftentimes prevent reintubating.
Thank you, Dr. Riccio. Dr. Foley?
So the thing that I think about what's nice about the SuperNO2VA is that actually you can put it on in the operating room. So right before extubation, you place it on, and as soon as you extubate, then you start with your SuperNO2VA and your CPAP, nasal CPAP, which then can be transported to the recovery room. So it depends on how far your recovery room is, and I can tell you for me right now at my ambulatory surgery center, it's a minute and a half to get from the OR to the PACU. So if I have someone that's just on an oxygen mask, it's not enough, and they probably are going to desat by the time they get to the recovery room. So that's, the transport is there for that, so then the patient goes on. The second thing is, again, what we talked about earlier, is the ambu bag being able to move, so if it's on the patient. So the nurses can say, oh yeah, they are breathing. They're not just looking at the O2 sat on that patient, right?
Sure.
They're actually seeing that they're actually ventilating, because the concern will be, it could be apneic oxygenation, and with the shortage of nursing and things like that, you never know that patient might have been apneic for a while.
Sure.
And that was always the argument. It's going to be a late indicator. So that's one of the other things that's nice about that. That actually you are visualizing. It's not end-tidal CO2, but it's still a good indicator that that patient's ventilating.
Yeah, absolutely. So how do you feel like these two modalities actually affect your workflow in the OR? From a clinical perspective, does it simplify your workflow? Does it make it easier? Does it eliminate a few steps that you otherwise might have to take to rescue your patient or bring back the patient to a state, a good hemodynamic state?
I think so. I think I use the SuperNOVA in the OR primarily on extubation. So if there is a patient who I am worried won't fly or will become quickly hypercapnic because, you know, they have morbid obesity or OSA, it gives me an added sense of, it's just one more level of safety where I know that each breath that they take will be augmented and they will ventilate better and they will come back to lucidity quicker, right? They'll wake up faster. And so I think that, you know, when used correctly, it can really speed turnaround times. It can speed time. It can speed up your time in the PACU. Like they can be discharged earlier. So I think that's a great device. In the operating room, we use high flow as the primary means of oxygenating and ventilating during airway surgery. So that, like we talked about earlier, I think has made that whole procedure much safer and much quicker.
Sure.
Less trauma.
Sure.
So for sure.
Yeah.
Thank you.
So for, you know, again, so the PACU, you know, extubation is one thing, and then also pre-oxygenation and apnea for difficult airway is again one of the things. And then doing a lot, you know, deep sedation for patients that have sleep apnea and things like that, putting the SuperNOVA on, you know, instead of putting an oral airway or, you know, nasal trumpet, I'm not instrumenting their airway. So this helps, just like the high flow. So they both kind of, in that respect, they both work pretty much the same way. Sure. They're both effective for both pre-oxygenation, apnea oxygenation, and then in sort of intra-op for deep sedation, I think. The thing is, I think that it's the transport from the PACU, from the OR to the PACU, that high flow kind of has that.
Oh yeah, for sure. You can't rescue ventilate with the high flow. You can't transport because you'll blow through your tank super quickly, right? But I would also say like apneic oxygenation with the SuperNOVA during, you know, a 10-minute window maybe for intubation, but it doesn't measure up to the ability of the high flow to apnically oxygenate for longer periods of time, like we're in the OR.
So I don't think there's been any studies showing that, but they have shown studies up because studies have shown up to at least 12 minutes. And so, yeah, you're not going to see that because there's no indication to do that for the patients in the OR, unlike your ENT cases.
Right, it would be our ENT surgeries can oftentimes be longer.
But you know, the other advantage, which I really wanted to bring up, but thinking about this is also we can take the SuperNOVA in the MRI suite. Yes. There's no metal, there's no indication. Yes. Again, the other thing is we can monitor end-tidal CO2 while they're deeply sedated. So that's key because you're in another room and they're like in this tunnel.
Well, so the alternative to this is really not high flow versus SuperNOVA, it's SuperNOVA versus intubation.
Correct.
Because most people would just intubate those patients because they have a secure airway. Like, I don't know if I would feel comfortable in another room deeply sedating someone wearing anything, a nasal cannula, high flow, or a SuperNOVA, you know? So it's a personal preference as to are you going to sedate or put under general, right? Point, yes. So, like, that's not really high flow or SuperNOVA, it's SuperNOVA.
It just can be used into the, but it can be as a substitute.
Exactly. But that was a very good point.
Yeah. Yeah, it is.
Can you share any possible or potential complications that either one of these therapies may cause?
Complications from the high flow, I mean, I would say would have to do with, like, sometimes if it gets dislodged, it can give you actually a corneal abrasion or something, right? Because it's blowing, right? So I've seen that. I honestly do not think it leads to significant gastric insufflation, especially if their mouth is open.
Have you had any experience with nasal?
No. The humidity and the heat, like they do not complain of that at all, really.
Okay.
Yeah.
Dr. Foley?
So with the SuperNOVA, I mean, so the only thing that you might do is because you have the mask on tight, it will just put some red marks on your face, but it doesn't cause any like real damage. I mean, I've had them on for 4 hours or so for long cases, and that seems to be okay. I mean, the concern is because it's not humidified, but for that long length of period, patients aren't complaining of dry throat or sore throat either. And so, and again,
How high of a flow are you putting through it?
10 liters. Yeah, so that's the reason why. So you're not using the high flows, and you need the humidification at even 40 liters per minute because you're drying. So it's only 10 liters per minute, so you don't have to really worry as much about the dryness.
Any worries about gastric insufflation with SuperNO2VA?
No, there was one study that actually looked at gastric insufflation with the nasal CPAP, or it might have been actually a full face mask one, and it was on gastric bypasses, and they kind of looked to see afterwards if there was any increase in air in the stomach, and there was shown to be none.
Okay.
So that was just one study. I have to pull that up.
Oh, that's great.
Yeah, I mean, I would say if their mouth is open, I don't think you have a risk of.
Right. I mean, the questions come up sometimes in different facilities and from different clinicians as well.
Oh, sure.
So it was good to at least address it and get your opinions on it. Any final thoughts, anything that we should have asked Dr. Riccio, Dr. Foley, that you can maybe add on to here to this conversation?
I mean, I think we could sort of summarize. So if you went through these 4 topics and said, okay, using it for pre-oxygenation or difficult airway management, both are probably equal, right? I mean, I think the only difference is you couldn't easily intubate with one of these on, which, you know, and that again is personal preference. Like I tend to, in more difficult airways, actually nasally intubate because it is just a more straight shot to the cord. So for me, I think it's kind of, and it's especially awake, it's like less gag inducing, right? So if I don't have any time, I would go with that. But I would say both do that job well, right? Then in the OR for mitral laryngoscopy, I think high flow is the clear winner. Okay. Just as it doesn't get in the way of the surgeons. It gives, you know, a tubeless field. It's humidified, right? So you don't have any of those complications. The only problem, well, it doesn't measure CO2, but those patients aren't breathing anyway. So you're going to have a rise of CO2. For the NORA environment, I think this is a clear winner, right?
Yeah, it does, because you can rescue. And I think the other thing of that apneic oxygenation is that's one of the things I think which is a great advantage is that you can nasally ventilate, nasal ventilation.
Oh, sure. Yeah.
And it's actually, there is one study that compared nasal ventilation versus face mask ventilation and showed that nasal ventilation actually had increased tidal volumes and increased peak pressures versus the full face mask.
Okay.
Like more greater volume with lower pressure, right?
Correct.
Yeah, right,
yeah.
they do. And I actually have a colleague who has since retired, but he trained in Great Britain, and he said years and years ago, all they ever did was nasally ventilate. There was no full face mask ventilation. Really? Yeah, so in that regard, it's beneficial. Plus, you can transport with it. You know, and as you're churning and burning through GI cases, again, you have a higher level of safety when you leave one patient in the PACU and then go get the next one. Sure. I think you have a little bit more confidence in the fact that they're going to do okay, right? And then in the PACU, I think the biggest thing is availability, really.
Right. Like how many do you have of those in the in the PACU? What?
I mean, I have 0. If I needed one in the PACU, I would have to call respiratory or call my anesthesia techs and have them set it up in the PACU, right? Whereas this, you could just throw on the bed, or they're wearing it from the OR. Absolutely.
So your speed of intervention and rescuing the patient.
Right. You would have to think ahead of time to use this, and then, you know, you're putting them on a face mask and they're de-recruiting, right? Whereas if you put them on this, they're maintaining their PEEP and all that, you know, which I think is probably better medicine. But I think they both do the same ease of breathing.
Sure. Well, Dr. Riccio, Dr. Foley, thank you very much for being with us today. Great insights. You guys are very, very experienced, and we appreciate all the information that you gave us today. Thank you.
Thank you.